بسم الله الرحمن الرحيم. بيشرفني ويسرني جدا ان انا اقدم دكتور احمد باغافر، كونسلتنت اوف بيدياتريك بي اي سي يو في مستشفى الهيئه الملكيه بينبع. هيقول لنا محاضره عن الاكيوت ريسبيراتوري ديستريس سيندروم ابديت.
السلام عليكم ورحمة الله وبركاته. Morning everybody. First of all, I would thanks Dr. Baghafar and the organizing committee to allow me to share you in this great conference. And we will start directly because we have this big topic. Bismillah ar-Rahman ar-Rahim. Today we will speak about the update in the ARDS. As everybody knows that the ARDS is one of the most difficult and common in the PICU, and it is a little bit confusing and difficult until these days for all the intensivists. So this is our objective. We will speak about the ARDS prevention, ventilation modes, adjuvant therapy, and the new thing of biomarkers and COVID. As we know, everybody knows that the COVID is the new thing that everybody is spoken. So first of all, the ARDS was defined in 1967 as first. Then in 1992, the American European Consensus Conference established some specific diagnosis criteria, which was adjusted in the what they called Berlin definition in 2012. And they said that the timing of the respiratory failure should be within 1 week of admission, bilateral obesity for chest audiogram, and origin of the respiratory failure away from the liver, from the heart failure, heart function, or volume overload. And they put the oxygen criteria. They said that at least patient should be in deep 5 with BF ratio if less than 100 is severe ARDS, from 100 to 100 moderate, and between 200 and 300 is mild ARDS. This is the criteria. It was adult oriented. Then the Pediatric Acute Respiratory Distress Syndrome Consensus Conference, they did the Pediatric Acute Lung Consensus Conference, which is called BALIC in 2015. They put the criteria special for the pediatric, and they give the definition of acute onset of non-cardiogenic pulmonary edema, hypoxemia, and need of mechanical ventilation. Pediatric ARDS clinical syndrome caused by disruption of the alveolar epithelial endothelial permeability barrier unrelated to cardiogenic pulmonary edema, and it have two causes, either direct or indirect. So direct, it affects the alveolar epithelial, and indirect coming from the bloodstream affecting the capillary endothelium. They put their criteria, which is more or less adjusted from the other criteria. They exclude only the age of prenatal due to RDS syndrome, for the neonate. And they said within 7 days, the same origin away from the cardiac failure and volume overload. Chest imaging, they said that is only a new infiltrate. They didn't need bilateral infiltration. And they put the theory for the oxygenation. They said that for the non-invasive mechanical ventilation and invasive mechanical ventilation. So non-invasive, they need CPAP of 5, and they need BF ratio less than 300 or SF ratio less than 264. And for this one, they need the face mask or bi-level. And for the invasive, they put they divide it to mild, moderate, and severe according to the oxygen index, or for more easier oxygen saturation index, as we will speak about this. And as everybody knows that we have in the pediatric a lot of cases of cyanotic heart disease and chronic lung disease coming from the neonate. So they put special criteria for this one. It's almost the same for age, time, origin of the edema, but they say if the oxygenation needed not explained by the underlying cardiac disease, this can be added, or not explained by the chronic lung disease, so they need more oxygen than the usual, they can add this patient to our criteria, which will make a lot of patients coming to us, and we will not lose any of our patients. So what is the oxygenation index? Oxygenation index is depending on the FiO2 you are giving to the patient and the mean airway pressure from the ventilator, and it will be divided by the partial oxygenation pressure in the arterial blood gas. So this one need arterial blood gas, which is usually in the adult, it's very easy to take the arterial blood gas. In the pediatric, if you don't have the arterial line, which even difficult for most of the children and need special technique. So even taking arterial blood gas sample, it's very difficult and have a lot of complications. So they change it to oxygen saturation index instead of BaO2, which is saturation in the blood gas. They take the cutaneous saturation, oxygen saturation, the usual oxygen saturation, and they use it for this one. And they have the criteria as we see. The incidence is from 2 to 5.7 per 100,000, and most of the children are under 5 years, which is this ARDS, mainly it's coming like 10% of the all BICU admission with huge high mortality reaching to 40%. A risk factor, a lot of risk factor, pneumonia is the main, sepsis is the other one, aspiration, trauma, drowning, a lot of things. But the main mortality coming in the sepsis and in pneumonia. And there is a huge mortality coming in the drowning or non-septic cause, but the number of cases we are seeing is little comparing to the sepsis and to the pneumonia. So most of the cases coming pre with ARDS, it's not ARDS. Within 48 hours, it will be shifted to ARDS. So need a hero to stop it. So prevention is the first management for all the disease. So we will start with the prevention, trying to prevent deterioration of this patient. So when the patient coming with pneumonia, sepsis, we will start with all the management of these cases. But the only thing they are looking for is the fluid resuscitation, because previously when we have patient coming with shock or coming with dehydration, we are giving fluid. Then we are thinking it's the inotropes and the other. This thing even changed in the pulse recommendation, and they are going now to fluid, assessing the lung, then giving the inotropes faster than before. So avoiding positive fluid balance after a period of shock, and even for the blood and blood component, it's the same thing. So monitoring the fluid balance is might prevent the development of ARDS. Again, if you need to ventilate the patient coming in shock, patient coming in cardiac shock, patient coming on pneumonia, so please use lung protective strategies with low tidal volume and high beam, which will protect. Again, lung protective ventilation strategy may prevent lung injury in mechanical ventilated patient without ARDS. We are not reaching still to the ARDS, but if we reach there, please don't panic. We will start management. So management of the pediatric ARDS is focused on a few things. The first thing is the diagnosis and the treatment of the infection. You have patient coming with pneumonia, good antibiotic, good management for the patient, and treat the cause is very important to treat the ARDS. The respiratory support is the main key player and the main management. Then careful fluid management, as we said, with general support measures and alternative treatment. So the first is the respiratory. This is the first thing. Respiratory support, we'll start with non-invasive, no need to hurry to the invasive. And there is a lot of study about the non-invasive, either the mask, CPAP, or the high flow. And they found that the NIV significantly reduced the rate of intubation and also mortality rate. And the high flow having no effect in the intubation. This is multiple studies done, but this is the conclusion for them. But they have significantly lowered the mortality, which is very important. Saving one life is a very, very important in the place. Again, we need anesthesia. Sometimes we need to sedate the patient not to fight with the ventilator. So need to sedate the patient well. If you fail, you may use the neuromuscular blocker. And we have a lot of study about this one. And they said that the early administration of cis-intercronium reduce the adjusted 90 days mortality and barotrauma and increase the ventilator-free days without increasing in muscle weakness. So use it early and use it with the optimum initial dose. Keep the patient quiet, not to fight with the ventilator. You can ventilate him very smoothly. It will decrease the pressure and decrease the barotrauma. As we said that the conference or Pediatric Acute Lung Consensus Conference, they put the guideline, and their guideline for the neuromuscular is when used in the pediatric patient should be received minimal yet effective neuromuscular blocker. They recommend for daily holidays if possible, and a lot of recommendation. This is the main thing. So titrating the beep. The beep is one of the pressure using by the ventilator to keep the lung open. So we are keeping minimal pressure to keep the lung open, not to collapse every time, collapsing and reopening. This one will increase the shear and tear. So the main cause is to keep all the lung is open, recruit and prevent atelectasis, will improve the oxygenation. And there is multiple studies, they said that there is not affecting the mortality, but it's improved the ventilator-free days, which is very important that we have this one. And it will keep our bed is free, keep the patient is free from the ventilator, improve his life. He will not need sedation. He will be more active, can be managed easily. So the basic recommendation for this one is we recommend moderately elevated level of beep from 10 to 15, titrated according to the condition and the oxygenation need. And they recommend the use of patient-specific tidal volume according to the disease severity. So if the patient having high pressure in the ventilator, use more protective measure, go to tidal volume 3 to 6, increase the rate to improve the oxygenation and CO2 removal. And if you need, you can increase it to 5 to 8, but if the pressure is allowed. Protective measures mean high beep, low tidal volume as possible. Applying a stepwise lung recruitment maneuver, they are using the beep, increasing the beep for a few minutes, then decrease it. It will open the lung and recruit it instead of using the ambo bagging and doing the manual recruitment. So they are using, as we said, the beep, they are increasing the beep, increasing the main airway pressure, then it's decreasing within 5 minutes. They can do it every 2 hours, increasing the main airway pressure, improving the delta B and improving the patient condition. High frequency, one of the type of the ventilator we are using sometimes in the past too much. They have the advantage of being working in the area away from the atelectic area and away from the trauma. They are ventilating in the middle. They have better outcome from the barotrauma and polytrauma. And there is the ARDS, again, airway pressure release ventilator, which is coming in these days. And still we don't have a lot of pediatric studies, but it is going there. It's having the same criteria, one affecting the inspiration, one in the expiration. But again, it's not the preferable, because the adult, they found that it is not effective in the adult. So in the pediatric, they are recommended that high frequency selective ventilator should be considered as alternative ventilator mode in hypoxic respiratory. Nitric oxide, again, they don't find any effective, but in the pediatric, we are using it if we have pulmonary hypertension. You know that we have patients with chronic lung disease, we have patients with heart disease. Pneumonia itself will affect the right side of the heart, making high pulmonary blood pressure. So when we have documented pulmonary hypertension or right ventricular dysfunction, so we can use it to release this pressure. Again, another alternative mode is the prone position. Prone position being used, you know, the patient when he is in supine position for a long time, the fluid will stagnate in the lung, so it will overload and close the lower part of the lung. Half of the lung, it will go out. So shifting the patient from the supine position to the prone position can distribute the fluid over the lung and opening the atelectasis lung. So again, prone position during mechanical ventilation for patients with acute hypoxic respiratory significantly reduce the overall mortality. Have its problem because we are proning the patient for 18 hours and attending to the supine, need multiple persons to shift him, need special care for the airway and the pressure ulcer. So having some difficulty for the pediatric, but if we can do it, we should do it. As the recommendation, prone position cannot be recommended as a routine trial, but should be considered as an option in case of severe BRDS. So when we have severe pediatric ARDS and the patient for a long time, we can use it, it will improve the oxygenation. Surfactant, they try to use it from the, as we tried in the pediatric ARDS, they tried in the adult, they failed to find any result from it, and not showing any improvement in the mortality. So the Pediatric Acute Lung Injury Consensus Conference, they said that we cannot recommend it, and anything they are saying not recommended, we cannot recommend it. They are asking for a lot of study to be done and trials to be done after that. You know, this done is 2015. In 2019, Wolfler et al. Came and they said that the surfactant, there is a lot of study done and few trials in the pediatrics. So they did a visibility study. They tried, they say what's the impact, and they say that it is improving the oxygenation and DF ratio, oxygen index, and pH in the children population with moderate to severe pediatric ARDS caused by multiple. So it is feasible. There is the era to go for it, and we will try it. We will do it. Again, steroid, the magic medication we are using, we loving it. Everybody loves steroid, but it has a lot of impact on the children, and still a lot of users having no proved on it. So again, for the Balic, they said again cannot be recommended. So they need a lot of study. They need to do trials. After that, in 2018, another study done, and they said corticosteroid use in the pediatric ARDS remain an important clinical question, and they said that using it in the first 3 days with a small dose, like 1 to 2 milligram per kilogram per day, can be effective and can be used and used right. The new era of medicine and for the investigation, the biomarkers. You will listen about this biomarker in most of the critical things, in the sepsis and the ARDS. Science, they are looking for the biomarkers to see the prognostication of the disease, how it will go, it will improve, or it will be going downhill and the patient will die, and sometimes to guide the treatment. So biomarkers, again, being tested for the ARDS, multiple biomarkers, plasma nucleosomes, interleukin-1 antigen, and plasma interleukin-8, multiple, you will listen to it. And this study, they said there is 11 biomarkers being tested and a lot of study being done with good p-value, but still the practical effect on it, it's not there. And they have only the biomarkers, but they don't know how it will progress. And we will see in the next days the effect. So all what we need is to listen to this one. There is something called biomarkers. We need to know, we need to follow until we will have a good result. COVID-19, the thing that we are, the guest that it is not invited and not welcome, but it is there, unfortunately. So we will face it. And with the report, we know that the ARDS is the main cause of this death in COVID patient. Alhamdulillah, thanks to God, that it is in the children is more less commonly than the adult. And they said that the ARDS natural, it's almost the same ARDS like the other ARDS we face in the pediatric. Why it is less affecting the pediatric? They said that because of the difference in the receptor for renin-angiotensin system, still it is not mature enough, and altered inflammatory response in the pediatric group. So how it will come in the pediatric? It will come with acute respiratory distress, myocarditis, septic shock, DIC, and acute injury of the lung, of the liver, and renal. Again, there is an information that they said that the child who is confirmed to diagnose COVID-19 had milder clinical course than suspected case. So why is this? They said that as we know that it is the COVID is mild, so sometimes you will have the patient coming with pneumonia with all the signs, coughing, fever, and respiratory, he's desating, X-ray showing infiltration. All this you will think about COVID, except especially in this stage. But if you don't have the PCR for other virus, you look for it. Maybe it is influenza, parainfluenza, it's any other, even if it is any other respiratory virus. So these respiratory virus, other than COVID-19, are more affecting the lung for the children more than the COVID. So if it is confirmed it's COVID, it's inshallah will be less affecting the child. So from the recommendation, again, they love the prone position, even if the patient is not intubated yet. You can use it and just take care about the child and don't delay the intubation if you need it. Again, another new modalities is the ultrasound. Ultrasound is coming very fast. It's very effective, and everybody is loving it in the ICU. So it's a small device, you are using it, you can see the cardiac output, you can see the lung condition, you can see the fluid where it's collection. So one of the things that they tried in the COVID-19, they tried in the adult and the pediatric, and they said that the most affected area is the right upper and lower, the right middle and lower lobe, and the left upper lobe. And they said it's having the same criteria like other pneumonia. It's having alveolar damage, edema, interstitial thickening, and gravitational consolidation. This is the ultrasound. They are using the ultrasound to see the B lines when they are putting the probe. There is B line, there is A lines, according to the lung condition. If the lung is clear, they will find the A lines. If the lung is affected or having fluid, it will be more B lines. Then it will be more mated. Then it will be consolidation. So the lung condition is worsening from position to the another. So a lot of study again. We took just 2 studies. They said that the lung ultrasound allow the operator and the clinician to determine whether the patient is in the spectrum of COVID-associated lung injury or not, and if it is used by an experienced doctor, it is useful, especially in the children, to monitoring the pediatric COVID pneumonia and its condition. So as the end, without being, so the pediatric acute respiratory distress syndrome is a significant cause of mortality and morbidity in children, unfortunately, but we need to be very careful. And we will start, as we said, with the prevention, then the lung protective measures, then we will try everything according to the condition of the child. So beyond the protective ventilation, there are limited data to support the management, but this is an era for the future clinical trial. Thank you, and special thanks for all our heroes from the healthcare workers working in the COVID, and hope you enjoy it. And we are happy to listen to the questions, your questions, and we'll answer them, inshallah, at the time.